شكرا جزيلا دكتور حسين، يشرفني طبعا ابقى موجود والبانل العظيم اللي موجود هنا. انا ام جوينج تو شير. انا على فكره كانت رساله الدكتوراه بتاعتي بيدياتريك كاتراك سيرجري ابتديت بيدياتريك. انا هشير معاكم انترستنج كيس. يعني دي patient came for me عندها 18 years old. she did يعني she gives history 12 سنه او اكتر، عملت كاتراكت وانتراكرال لينس. ال uncorrected visual acuity 260، البيست corrected visual acuity تتحسن اشاره 20/70 بلس 12 مع يعني spherical equivalent. ف ده slit lamp examination ليها. عايزكم تركزوا كويس في يعني البيوبل اوفل في شكل غريب كده، فتفتكروا ايه ده؟ It's very interesting. يعني طبعا يديك شويه من الهيستوري، انا شلت جزء من الهيستوري، عرفت ان هي قبلها بكام شهر راحت تعمل ياج ليزر في مكان كانوا كرمه جدا، فعملوا ياج ليزر يعني بذمه زياده. فاكشلي this is a perforated PMMA lens. ف what would you do؟ البنت الفيجوال بوتنشال بتاعها مش هينفع نسيبها كده، هي دلوقتي اكنها افكك. فالكلام الدكتور محمد كان بيقول عليه لازم نبقى حاطين في اعتبارنا ان احنا if we can implant primarily اللينز في الكابسولار باك this is the best location عشان it might be easier to exchange the lens. لان في الاطفال دول بيحصل ان السينيكيا مش بس بتبقى على البيوبيلاري مارجن، دي كمان بتكستند على الباك of the iris. فهنا I'm checking. I didn't expect it to be that difficult. I'm planning to exchange the lens by explore the situation. Dissected the posterior synechia, and then you can see how the synechia extends along the back of the iris على الانتيريور كبسول وعلى اللينز الموجوده. فدايما you have to put in mind if you going to exchange a lens or to deal with such cases after a long time, expect it's not easy. I'm here trying to cut. This is يعني a few years back. So I was going on to thinking that it will be easy just to exchange the lens. No, it's not easy. And you start to regret that you started the surgery in the first place. You have to be patient. See, it's a PMMA lens, so it's very difficult to cut it even. So you have to enlarge the incision. I'm getting it out. So this is my first mission now, is to get this lens out. I cannot cut it. So I will widen the incision. And then get the lens out. You can see there is vitreous. I'm pulling vitreous, you can see the vitreous. So you can see the lens. وهنا بثبت زي حركة الساحر. You see I'm passing through the lens. يعني ده ياج laser. Vitrectomy first for what is prolapsing from the wound, and then dry vitrectomy, and then with low infusion, high cutting rate, clearing the vitreous, and then started to think to tackle the problems facing me in the next few minutes. I want to reimplant the lens. I want to make sure there is enough capsular support, clear of posterior synechia that is extending to the periphery. There is no vitreous now. Clearing the whole area. If you don't clear the whole sulcus, then the lens, if you place it, it will be displaced. This is a 3-piece lens, foldable lens, but I'm using it because for better haptic use, manipulation, I can manipulate it much easier, and better quality of the optic. Now the lens is placed in the sulcus, and then you should start to think how to tackle this iris. Remember, the iris is friable in many parts. You stretch it. There is peripheral anterior synechia in some parts. So I'm trying to examine the iris and see if I can do some sort of pupilloplasty so the IOL will stay stable and the vision will be less distorted. Closing the main wound. And then doing pupilloplasty. It doesn't have to be very impressive, but it has to be functional as much as possible. You don't have to get everything back to normal, which is difficult because the iris is not really healthy in all parts, but at least to constrict the pupil so this decreases the glare for the patient and improve the visual quality for this child. This is 4th rows knot. One of the easiest, nicest things in doing iridoplasty is just interrupted knots. You don't need to do a purse string, which takes a long time and a lot of experience, a lot of effort. Just you can place as much as you need of interrupted sutures to fashion a nice looking and functioning pupil. And functioning pupil is much more important. So this is the end of the case. So I thank you very much. Thank you for the invitation, and I hope it is clear. Don't overdo YEC capsulotomy in a patient. And again, if you are going to treat for IOL exchange in such patients that were operated long ago, be prepared to face a lot of difficulty. Thank you for your attention, and I invite you to in next November for the sister society meeting, international meeting next November, inshallah. Thank you very much.